Assalamu alaikum, dear students. I hope you are fine even in this adverse situation. Today I'm going to a class regarding exam orientation of those two subjects that I have already discussed in my two previous classes. This is my third class. I will try to tell you regarding the exam oriented problem in this class. And you have to go through your clinical method book, and you have to read it, and you have to, if possible, you have to do the examination at home if it is possible. And I'm going to tell you what type of questions you may ask in the exam. You may ask for examine the child for anemia. Then you have what to do. You have to do a general look on the child, and usually there is generalized pallor, and you have to see the eyes, that is the lower palpebral conjunctiva. Both of the conjunctiva is you have to see at a time, and it is pale. And tongue, which is, as I have discussed in my previous class, it is pale, smooth, and shiny. And the smoothness is due to lack of loss of papilla. And this is stomatitis, and this is chelosis. And there is also, you have to see the palm and sole, and there is pale, there is pallor present in the palm and sole. And you have to compare the palm of your own palm with the palm of the patient and sole of the patient with your own palm. And you have to see the condition of the nails, that is the koilonychia. It means nails becomes smooth, spoon shaped, and you have to look from the side, not like this way. You have to see from the side, and there is loss of normal convexity, and it becomes spoon shaped. So you have to look skin, lips, oral cavity, nail bed, and conjunctiva. Nails are flattened, fragile, and brittle, and ultimately it becomes spoon shape, what we call it koilonychia. Forget about these three stages. And as I have told, there is atrophic glossitis, that is tongue becomes pale, smooth, and white, angular chelosis, and stomatitis. And dysphagia, it is not a part of examination, it is a symptom usually present in adult. And if a case of thalassemia is available in your exam during short case, you may ask for examine the child, abdomen of this child. In thalassemia, you have to follow the normal protocol of examination of abdomen. There is inspection, palpation, percussion, and auscultation. In inspection, it is normally in patient with thalassemia, abdomen is distended with centrally placed, sometimes in everted umbilicus if it is hugely enlarged. On superficial palpation, there is no tenderness or rigidity. And on deep palpation, you have to see the liver and the spleen. Liver is usually enlarged, mild, moderate, or severely, it may be severely enlarged according to the age of the child and the condition of and the management that received by the baby. If it is uncared, there is if the baby is uncared, then there is huge hepatosplenomegaly. So how you have to examine the liver. It is written in your book, in clinical method book. You go through your book and try to understand. But I'm telling here that you have to start palpation of the liver from the right iliac fossa. Your radial side of the uh, index finger will be parallel to your subcostal margin, and the tip of the fingers are lateral to the rectus abdominis muscle. And during the depth of inspiration, you have to palpate, you have to proceed upward and try to palpate the lower border of the liver. And when you get the lower border of the liver, you have to measure the size of the liver, how long it is enlarged. It may be mild, moderate, or mildly, moderately, or severely enlarged. And margin usually sharp, and it is non-tender, and the surface smooth, and upper, you have to percuss for upper border of the liver dullness. It is usually on the right fifth intercostal space at the right mid-clavicular line. And when you palpate the spleen, you have to start again from the right iliac fossa, and diagonally you have to go towards the left hypochondrial region. And you have to try to palpate the spleen during the depth of inspiration. And when you get the tip, usually tip is rounded and there is splenic notch, and the margin is rounded, and surface is smooth, and it is, you have to measure the enlargement of the spleen along the long axis of the enlargement. And you have to do the insinuation test. And when the spleen is enlarged, insinuation is not possible. How insinuation is done? You have to try to insert the finger underneath the rib case, between the rib case and the spleen, and it is not possible. So insinuation is not possible in case of splenic enlargement. And on the, here on the left side, there is another structure, that is the kidney. And when kidney is enlarged, you have to differentiate the structure, that is the spleen and kidney on the left side, and you have to differentiate it. You have in case of spleen, it is enlarged obliquely towards the right iliac fossa, but kidney, it is enlarged towards the left iliac fossa. Long axis of the kidney is towards the left iliac fossa, and the there is splenic notch within the spleen, but in kidney there is no such type of notch. And spleen is not ballotable, but kidney is ballotable. Insinuation is not possible in case of splenic enlargement, but insinuation is possible in case of when the left kidney is enlarged. And if you do the percussion over this enlarged spleen, it is dull but tympanic when the kidney is enlarged. So you have to differentiate between the enlarged left kidney along with the enlarged spleen. On percussion, actually there is no fluid thrill or shifting dullness is usually not present in thalassemia. Actually, it is not present in thalassemia, and auscultation bowel sounds are audible. On general examination, what you are supposed to get in thalassemia, there is pallor, mild to moderate jaundice, and thalassemic phases are very important. And bruise in the skin you may get in case of hypersplenism when the platelet count is reduced. Otherwise, there is no clubbing. In thalassemia, koilonychia is absent, leukonychia absent, palmar erythema absent, lymph node are not palpable, JVP will be normal, and edema absent. I have described already. You just read it out, what to do during abdominal examination. Again, there is another description. And X-ray skull, you may get a lateral view or anterior posterior view of a skull X-ray. Here it is the lateral view of a skull, and you in OSPE examination you may get this type of X-ray, and in your Viva examination, Viva board, you may get an X-ray and you may ask to describe this X-ray. So how will you describe this X-ray? This is a X-ray skull lateral view showing this from here to here. This is diploic space, and there is widening of the diploic space. And these are hair on end appearance of the skull bone, that is the hair on end appearance of the skull bone, and thinning or obliteration of the outer table of the frontal and parietal bone. Outer table is not visualized here. This is the inner table. So these three findings are very important for important finding in a X-ray skull lateral view of a thalassemic child. So again, widening of the diploic space. This is diploic space and hair on end appearance, and this is the inner table. It is visualized, but there is no outer table in the parietal bone, in the frontal bone, as well as in the parietal bone. Hair on this is inner table, no outer table, hair on end appearance of the skull bone, frontal bone and the parietal bone, and crew cut appearance on the X-ray skull. That is not the hair. This is the changes within the bone, within the diploic space. Outside this, there is scalp, skin, C for connective tissue, aponeurosis, loose areolar tissue, and the periosteum. Like that, it is distributed as scalp just over the frontal and the parietal bone and the occipital bone. So remember that. And another question you may ask in your Viva, if a child with thalassemia is available, you may ask for examine the look at the face of the child and give a running commentary like that. So how will you describe it? There is frontal bossing, parietal prominence. It is not well visualized here, but in my previous class, those pictures are better than this picture. And prominent zygoma, it is you can see here, and malocclusion of the teeth. Here you can see the malocclusion of the teeth and depressed nasal bridge or nasal bone. So this and also you can say the baby is moderately anemic and icteric if it is there. But if you ask for facial changes, you just tell these 5 points, not more than that. And X-ray hand of a child with thalassemia, It is usually not given in your examination, but still you see there is osteopenia, increased tubercular and mosaic pattern of the short long bones of the hands. So what type of multiple choice question you may get in your exam? You may have following like that. Following are true for thalassemia major. Following PBF findings are true for thalassemia major patient. Achha. Microcytic hypochromic anemia, it is true. Marked anisocytosis and poikilocytosis, it is true. Huge number of target cell, true. Spherocytes are present, false. Nucleated red cell present, it is true. So you may get this type of question in MCQ. In SCQ, like that, a 3 years child presented to you with moderate anemia with mild jaundice. What is your probable diagnosis? Write down 2 important investigation for the diagnosis of this child with probable findings. So this type of question you may have it. And another thing, at the end of the week after having classes, we are supposed to take examination, written exam. So this is the first question for your exam. You have to write it and you have to submit it on online. This is another question, 3 you may have in your SAQ exam. A 3 years child presented to you with moderate anemia with mild jaundice without fever. Write down two differential diagnoses. Write down the treatment plan of any one of your clinical diagnosis. A discussion on IYCF. You may have it as a short case, or you may ask in your viva. And in viva, you may ask like that: the baby may be on mother's lap and on breastfeeding in incorrect position. And we may ask you like that, please correct the position and attachment and tell me 4 points for good position and 4 points for good attachment. So you have to know the 4 points of good position and good attachment, and you have to explain in your examination in this short case, and you have to show it in correct form. Again, recapitulation of the 4 points of position. Baby's head and body and leg body in a straight line. A baby will be held baby will be close to the mother's body. Whole body will be well supported, and the baby approaches the breast and nose opposite to the nipple. These are the 4 points for position of a baby during breastfeeding. And attachment, let us have a look on position. Head, body and buttock in a straight line. Whole body, head, body and buttock is well supported. Baby's chest and abdomen will touch the mother's abdomen, and nose will be opposite the mother's breast. These are the 4 points of good position. Here you can see. Attachment, 4 points of attachment. In dark skin, you can see the areola clearly than that of the white skin. So here areola is not well visualized, but usually what happens if the baby is well attached within the breast, then in that situation more areola will be visible above than that above the baby's mouth than below. And baby's mouth is wide open. It is, you can see here, lower lip is turned outwards and chin close to the breast, or chin touches the mother's breast. So these are the 4 points for good attachment. With good attachment, nipple including surrounding areola is inside the mouth of the baby. Here not well poorly attached, only the nipple is inside the mouth of the baby. Here pressure is during breastfeeding, baby is giving pressure over the lactiferous sinuses, so baby is getting milk from the mother's breast. Here there is no pressure over the lactiferous sinuses where the milk is collected and it is available during feeding. So as there is no pressure over the lactiferous sinuses and the baby is suckling only, but there is no milk. In short case, in pediatrics, you may request for taking the feeding history of a child of 9 months, 12 months, or 15 months like that. You have to ask for prelactal feeding. What does it mean? If anything given before giving the breast milk, that is before giving colostrum, is called prelactal feeding. In our country, different types of prelactal feeding is given. Are given like mustard oil, sugar water, mystery water, but nowadays it is not practiced. Achha. And colostrum, whether it is given or not, and you have to ask for exclusive breastfeeding, whether it is given for completed 6 months or less than 6 months or more than 6 months, like that. And breast milk substitute, when and how it was given. It may be given within before 6 months, or at the age of 6 months, or after 6 months, like that, and how it was prepared with suji or rice gruel, in the form of rice gruel along with milk, whether it is given with the rice powder or not. And when complementary feed was given and with what. And you know, I have described the typical ideal complementary feed, what are those, and you have to ask for those type of foods, whether it is given on appropriate time or not. And you may ask for define exclusive breastfeeding. What do you understand understand by complementary feeding? And you may have now MCQ like that, and you have to answer like true, false. And this one is the following points are true for position, and this question is following points are true for attachment. And at the end, now I'm going to give you my email ID, and the second email ID, communicate with me regarding teaching purpose, please, and make a group in Messenger, and my cell phone number is 01711814940. One of you act as a volunteer to communicate with me over cell phone for your queries. Give me your roll numbers with name, please, through online. And please give your valuable suggestion for further improvement, please. And go through your books, textbook or clinical as well as clinical method, and try to do physical examination if possible at home, if anyone is available, like your younger brothers and sisters. So I think this class is helpful for you. And for suggestion, please give me your suggestions, please give me your advice for any improvement. We are passing very hard time, but we want to keep all of you with us. Pray for us. We are also praying for you, please. Thank you all.